Good luck,
Oh, thank you.
Yeah, and coming very soon. So we start the lecture, and we have patients that are ready.
Okay.
Yeah. Okay.
Good.
Yeah, great.
Okay.
Thank you very much.
Does anybody here speak English?
Yeah.
Does anyone speak Mandarin? I don't speak Mandarin, so I will speak English if that's okay. Okay. This is a small group. If you have questions, please feel free to ask. We can stop at any point to review things if they're not clear. I am fine with that. My name is Mitch Hardenbrook. I'm from Boston. I just got in last night, and I really like Taiwan. It's a beautiful place, and I'm very happy to be here. And I didn't really know what to expect, but I actually would love to come back again and spend more time. I'm only going to be here for the weekend, but it seems like an absolutely great country, and people have been so friendly so far. So thank you for that and the hospitality. My disclosures, I'm consulting with a number of companies. I own a few companies and I've had some patents not involving this technology, however. So, you know, when we talk about MIS surgery, we're talking about what I call reducing the trauma of spine surgery. And that trauma is going to be different depending on the type of procedure that you're doing. We heard today about minimally invasive T-lifts, where it's pretty clear that the muscle trauma plays a pretty major role in that. And reducing that muscle trauma, specifically the multifidus, seems to have had an improved impact on the outcomes. And so the question is what is important for microdiscectomy? What is the trauma we need to reduce to make that a better procedure? And it's important because each trauma is different pertaining to the particular procedure that needs to be done. So we know lumbar disc herniations, very common. I think in the U.S. there's 300,000 microdiscectomy procedures performed per year. A slight male predominance. And only of these 300,000, it only represents 4 to 6% of the total lumbar herniation. So in the U.S. and throughout the world, it's a very common problem that we're treating. Surgical decompression has a pretty good outcome, particularly in the short term, 85 to 95% improvement of removing the pain, the radicular pain. But as you follow these patients out longer, we're finding that there's other problems they tend to develop. So the question is, how do we improve on this surgery? What is the important trauma that we want to reduce to get the maximum benefit to the patient? And the first question we ask, well, is it muscle trauma like the T-lift? Is that what it is? And the research has been pretty clear on this. And you know, this particular procedure, paper in 2008, a retrospective review of 66 patients, open versus tubular retractor, so single level lumbar microdiscectomy. What they found was the open group had a little bit more requirement for morphine. The open group had a little bit more requirement for Vicodin. Surgical times, complication, everything else was pretty similar. Another study, larger study, 172 patients. Again, single level, tubular versus open. We have not been able to show a significant clinical difference between those two in output results. And I hate to say that because I figured it would be. This has been repeated multiple times. These are just two representatives of many, many papers that shows that reducing the trauma is not a significant contributing factor to improving outcomes in these patients. So what is the problem with this procedure? Well, it's recurrence of radiculopathy. Perigi, who is a spine surgeon based out of Stanford, I give him a lot of credit because he writes a lot of papers about his complications. He writes about what goes wrong in his patients, and from that we learn a lot. 33% have recurrence of radiculopathy in microdiscectomy. 26% of these are recurrence of herniation. The same pathology recurred after successful treatment. Reported 25% reoperation, 62% were repeat procedures. So you're repeating the same procedure in 2/3 of the patients in this particular study. So what are some of the problems that we're seeing with microdiscectomy? Well, there's recurrence of leg pain, secondary recurrent herniation. This can happen at any time. It usually happens suddenly. Symptoms are often worse. or similar to the first type of radiculopathy. The pain is not activity dependent. It happens, it's there, sitting, standing, they can't find a comfortable position. MRI with gadolinium shows recurrent herniation. There's been some research that shows there's a relationship between the annular defect and that recurrence rate. So perhaps reducing that might have a role. Another major problem is recurrence of leg pain in the absence of recurrent herniation. And I discovered this in the military when I was in the Navy. It usually begins about 6 months post-operatively. Symptoms are similar but not as severe. They're activity related. So the patient might feel pretty good doing simple everyday sitting at desks and working, but when they start to run higher end activities, the pain comes back and restricts them. And in the military, that means they lost their job because they can't perform the duties that they need to do. This is likely from epidural fibrosis, secondary to manipulation of the nerve root. So when you're talking about minimally invasive surgery and reducing the trauma, perhaps the trauma we need to reduce is to the annulus when we do the procedure and how much we manipulate the nerve root. And that's the premise for everything that I've done with this system and the procedures that I've helped to do research on. So hydrocision is the system. It's a cannulated system. It's a 4mm cannula. And it's done to not have to manipulate the nerve root. So when it was first performed, it was done through a standard microdiscectomy procedure where you did a hemilaminotomy, did not move the nerve root, and simply put a cannula in around the nerve root and remove disc material that way. So the 4mm annulotomy is a very small annulotomy versus the open procedure. And then by not manipulating the nerve root, you don't develop that epidural fibrosis. So how it works is you have a saline, comes through this module, accelerates through the handpiece and this tip to 900 kilometers per hour, very fast, very powerful. Through the Venturi effect, it sucks in disc material that comes into contact with it, pulverizes that material to the cellular level, evacuates it out into a waste bucket, and foot control. Okay? It consumes nucleus in a very predictable way. So this is looking at a younger patient and an older patient. This is time, 1 minute, grams of material removed. So slightly under 1 gram of disc material is removed for every minute that this is in contact with disc material. So the hypothesis is that by decreasing nerve root manipulation, we can decrease the epidural fibrosis, and we can minimize the recurrence of symptoms in the absence of recurrent herniation. And by having a smaller annular defect by how we perform the procedure, we can possibly decrease the rate of recurrence. So here's an example case that I did while I was in the Navy. Typical young patient, these are younger patients that we treat, 5-month history. Here's the MRI. You see a very large herniated disc pushing on the nerve root. So medial, lateral, superior, inferior. There's the nerve root. There's the disc herniation. So don't manipulate the nerve root. Stick in the guide wire into the disc space, followed by the dilator that dilates those cross-hatched annular coating, and then followed by the working cannula. So you minimize the defect that you put into that annulus and that ligament covering the annulus. And once you have access, with the pistoning, rotating, and wanding motion, you remove disc material at that consumption rate of just under 1 gram per minute. At the conclusion, you see the small annular defect. You can see the nerve is no longer flattened. You removed a volume of tissue. The nerve root, the remaining disc material can fall away from that nerve root and decrease the amount of pressure on it. So we reviewed some of our data from performing that and using the hydrocision technique. So this is now an open. So it's a hemilaminotomy approach comparing standard microdiscectomy to the hydrodiscectomy. This was presented at IMAT in 2007. So what we found is we had a decreased recurrence of herniation after a 1-year period of 17% recurrence in the open group down to 0. Now, 0 is an aberration, but this was statistically significant. It doesn't eliminate recurrences, but it certainly reduced it, both since this study, but particularly in this study. More difficult to treat the decrease of radicular symptoms in the absence of recurrent herniation, went from 21% down to 4%. And that's a very difficult problem to treat. There's no surgery we can treat. You can do injections and pain medications. Both of these were statistically significant. So, to me, this is proof of concept to go to the next step, which is percutaneous hydrodiscectomy. So eliminating that hemilaminotomy approach and simply just do a percutaneous puncture incision and remove disc material that way. So the percutaneous hydrodiscectomy, again, same dilation of the cannula, and we found 3 minutes. We've done a lot of study on this. 3 minutes of having the spine jet on and in contact with disc material removes enough material to decompress the majority of herniations, which would be just slightly under 3 grams of material. So comparing the percutaneous to the micro, the standard micro, perc, obviously there's no bony resection, there's no direct access, it's all indirect access. You don't visualize the nerve, so then you don't manipulate the nerve. It can be performed under local anesthesia, which everyone in the US performs it under local anesthesia, and takes about 15 minutes, really closer to 10 than 15. Obviously the micro, direct visualization, you can do some bony decompressions, but it does require general anesthesia, and it's more around 60 minutes procedure. So what are the indications for this? You'd like a contained herniated disc. I know that has various meanings depending on where you are. To me, it's subligamentous. I mean, it can't be extruded, it can't be a free fragment. If it's within the confines of the ligament, that is a potential herniation that I would do this on. Obviously, they have to have failed conservative treatments, physical therapy, medication, rest, epidural steroids, plus or minus. In the US, that's becoming more controversial. It works very well for far lateral herniations and recurrent herniations. So contraindications, obviously, if the disc is not attached, if the disc fragment is no longer attached to the disc space, it's not an indication for doing it. If there's any bones, spinal stenosis or osteophytic impingement, obviously that's not an indication for surgery. Spondylolisthesis, I don't know. Traditionally, you don't do decompression on patients who have instability, but perhaps this is a study that needs to be done. This would be a good indication if you have spondylolisthesis and you have a herniated disc in that setting, that you could potentially just do a decompression and not have to stabilize that patient. I don't know the answer to that yet. So the technique is an indirect, so it's sort of a discectomy or a discogram technique. Today, the technique you're going to see is much more of a lateral approach. Traditionally in the US, we're more of a horizontal. This is about 45 degrees to the horizontal. Today you're going to see closer to 25 degrees to the horizontal. And that allows you to get further medially. So you place the needle, there's your fluoroscopic image. You have this one-step dilator cannula that dilates the annulus, puts the cannula, you put the cannula into the annular space, or through the annulus into the disc space, and this stays in. That's what that shows. This is what the cannula looks like in position. You want to have it as close as you can get it posteriorly, so you have access to all the disc material that's most posteriorly. The concept of this is not to necessarily remove the herniation causing the problem, it's to remove a volume of tissue. That volume of tissue is going to create a space where the herniation can fall away. And as we've learned, it does not take a big change in that herniation to have a big effect on the clinical outcomes. People get better without surgical intervention with large herniations because of small alterations in that disc material. So this concept is to remove as little disc as necessary to take the pressure off the nerve. Leave it as close to how it was before you got there. That's the idea and that's the concept. And then there's pistoning, rotation, and wanding. And that way you keep the opening in contact with disc material, and that removes the disc material in that consistent 1 gram per minute. This is what it looks like on the lateral image. It's very important when you do this that you always get AP images. This is a case that was demonstrated in a cadaver lab where the cannula did not go into the disc space, but it skived off laterally, and so the microresector was actually lateral to disc space, and on the AP you can see that this is very dangerous. So you always want to confirm on that AP that you're within that disc space before you begin the procedure. Any questions about this? Today's procedure is, this is the patient. My understanding it's a 34-year-old female who has left-sided radicular symptoms, L5 distribution. This is a very good example of a perfect patient for the microresector. You can see this has a small herniation, has this what we would call a high-intensity zone. And so they're going to come in here, remove this tissue through the percutaneous approach. And that's the procedure that we're going to see today. Okay? Understand?
Do you advise the new performer to use this operation start with the openness, just like you do now with the...
I don't know that you have to do that. I did that because I needed proof of concept. I had to believe it was going to work, and I wanted to see it. So I saw, when I first saw this about 10 years ago, it was this. And they said, "Do you think anything we could do with this?" And so, yeah, I think you can move this material. So I wanted to see if it would work. And so I started with open procedures so I could examine and explore the nerve root afterwards. And I can say in all the procedures that I did that way, there was not one that did not get better. Now, some of them developed problems later on. Some of them did develop recurrences. But every single one of these had a period of pain relief. And I never once pulled material out with the pituitary. I only used this. So that gave me enough confidence that by removing a volume of tissue, I could consistently get the results that I was looking for, where I could go on to the percutaneous level. So I don't know that you have to do one before the other unless you personally want to have that same proof. But it's a completely different technique. So one's not going to help you do the other one better. It's a different technique.
Sir, excuse me, can you get back to the case you presented previously? That L5 is one MRI. Yeah, you just no previous one. Yes, you just perform an open method.
Mm-hmm.
Yeah. Yes. Yeah, is this a good indication for
Percutaneous?
Yeah.
I don't think so. It's too big.
Too big.
This would be stretching the limits. This is bigger than 6 millimeters. I don't know if I would do that percutaneously. That's a big fragment.
After the surgery, what will be the pressure profile when the disc is under loaded condition?
The pressure?
Pressure profile of the disc.
I don't understand.
Now, when you put the disc on pressure, say standing, what will happen to the disc? Because what you remove is normal disc material. Will it change the
Right.
disc stress profile?
Yeah, I don't know. That's a good question. I've certainly never directly measured that pressure profile. I think it's not. I would disagree that it's not normal material that you're removing, because in order for a disc to herniate, it has to have some sort of dehydration that's going on. But I don't know if I could. No one could speak to.
If I put the question in another perspective, is will you accelerate the degeneration of the disc by removing some of the material? Will you accelerate the process?
I can answer that with an example. There was a patient who was a Navy fighter pilot who had the procedure, the percutaneous procedure. They would not let him go back to flying unless I got a second MRI a year later. And this is only an example, but a year later, you could not tell any difference between the dehydration and the degeneration of the disc from the pre and post in 1 year. I don't know how often you get MRI, and it's very rare to get an MRI in an asymptomatic patient post-operatively, but that's the Navy.
Okay.
That's the military, they require stuff like that. So, in my N of 1, I found it did not accelerate at all, and I think if you compare to physically incising the annulus, and when you remove that disc herniation, how often do you go in and take out more disc, and more disc? In the U.S., there's two different types of surgeons. There's those who take out a minimal amount, and they have higher risks of recurrences, but the belief is they try to keep as much disc material there for future. Versus someone who says, I want to do basically a subtotal decompression, where they remove more disc than you would need to. They get no recurrent herniations, but the disc collapse is pretty profound. I think this would be more in that first category, where you're going to have less.
Okay.
But I don't have data to back that up. Yes?
The indication of the hydrocision
Yes.
is just limit in the contained disc.
Contained
herniation.
/
The annual fiber is
subligamentous.
intact. Annual fiber annulus is intact.
I would not limit to just that. Definitely
Because you
subligamentous.
You emphasize the puncture hole
Yes.
into the,
Yes.
the disc space,
Mhm.
and so the annual fiber is intact, is healthy.
Yes.
You emphasize these concepts.
Right.
And you have any experience to treat of the discogenic pain?
With this?
Axial pain, just back pain?
Yes.
Have any experience? Have success?
Not personally. I know surgeons who do that in the U.S. With varying degrees of success,
Yes.
just like every other treatment for discogenic back pain. Specifically, Dr. Jasper has done a number of these for discogenic pain. I'm not willing to say that I would recommend that without, maybe under experimental conditions to sort of see what that would do. But I certainly don't do that.
Just like this case, there's a degeneration disc herniation, and in the L5S1 label.
Yeah.
Is if not too much bulging disc, you can use percutaneous hydrocision
Yes.
to do this procedure
Yes.
to L5S1.
Yes.
Yeah.
L5S1. It's more challenging sometimes because of the anatomy.
Yes.
Getting to it. So
I think
there are
it's
cases
just-
where you cannot get
Maybe
there.
just leave it in female. Female
Yes.
is easier.
Well, you can see this is for L5S1. It's got the angle
Curve.
to help to get around that area.
But the dorsal part, the hydrocision, is very difficult to remove. Dorsal part, because the angle is very
Because the
sharp.
angle, yes. Yes.
I have the same question that how do you know this is contained or not contained? Do you use MRI to tell what is this the contained this or not? And the second
There is, okay, I'm sorry, go ahead.
The second question is that how do you know you have the offended disc already adequately removed? The volume, how do you know from the volume? How do you know this? The nerve is actually adequately decompressed. Right. This
Yeah. I'm presenting data on 50 patients tomorrow about the outcomes of these. And an answer is you don't. Percutaneously, you have no way of measuring, you have no way of knowing. We found that about 2.5 grams to 3 grams of disc removal seems to be enough to decrease. I've tried to do shorter amounts, less, and have had less success. So that 3 minutes, continuous disc contact and removal about 2.5 grams seems to be around. You can't confirm that intraoperatively. You can ask the patient, but they're not going to be able to tell you right away. Sometimes they can, because they're awake, and you can, right after you finish, you can ask them, and they'll say, yeah, I feel the difference, my leg pain is better. But you can't confirm it. It's a procedure where you're removing a set amount of disc material. And the data shows that it's pretty effective, but that's all we can go by. What I use to see if it's, now I don't like the term contained. I've never liked that because it's confusing. It's different, it means different things to different people. So I call subligamentous. I call it subligamentous. And the way you find that is on the sagittal view. You can see the ligament will be coming over the top of it. And it's usually more central than this, so I can't see it on this one, but it's on the sagittal view of the T2 MRIs. You can see the ligament come on top of the disc, and that's how you know it's subligamentous. To me, that's a term that makes more sense to me than contained. I'm sorry I used contained, actually, because I don't know what that means in
Maybe
different places.
with the endoscope, you can see clearly the nerve have been adequately compressed and the free fragment have been removed adequately. So your method with this a little bit like blind method to
Yes.
you
You can do this through an endoscope as well. It's compatible with many of the endoscope systems. So if you want to have that visualization, you still get that same approach, and the techniques of minimizing annular disruption are still there. And you can visualize, which obviously for surgeons we like to do that when we can. Yes.
Would you mind tell me how do you use the anesthetic during your procedure? And secondly, do you use corticosteroid after your procedure?
I do. I inject Decadron 100% of the time on the way out
And
after the procedure. So the patient is awake, prone. I use local anesthesia at the skin. I place the needle into the position, and then I inject anesthesia coming out, and I place the needle again in the guide wire. And when you place the dilator, it's very uncomfortable. So I usually give the patient some propofol, just to get a 5-second, get that through the annulus, and then once then that's all they get for the entire procedure. When you're actually removing with this, they don't feel this. Now if I'm really trying to cover a lot of area where I'm wanding quite a bit, they're going to feel that on the annulus, and so it'll be a little sensitive. But for the most part, when this is in and you're doing the procedure, they don't feel that. And then as they come out, I inject, I do basically a transforaminal epidural steroid as they come out. And it takes about 10 minutes from beginning to end.
But if you injection the steroid, how do you distinguish the effect from your decompression or the steroid epidural injection?
Everyone who gets this procedure, for me, has already failed epidural steroids. So they've gotten those injections and they haven't worked. I figure I'm already there, why not add it? Now for the sake of science, if I was going to design a study, I might not do it. But for the sake of treating the patient, I'm there, I'll inject it, and it's failed in the past before I've done this. And so if it works this time, it's probably a combination of the two. You know, I think just removing a little bit of material with the anesthetic, with the steroid, is what makes this effective.
How many material you will remove from your canal? How many material, nucleus, you will remove from your procedure?
How many?
Nucleus you will remove from your device.
You mean levels in a patient?
Yeah.
I've done 2 levels, and is the most I've ever done in a single patient. I've done more than one level. I've done one level more than once in a couple of patients where they had recurrence, and I repeated it.
Another question: may I use some faucet into your canal? They have some faucet very small, so I also can pass through your canal,
right,
and remove the more nucleus. Maybe then you will device.
It is impossible because the small faucet, just straightforward.
Not too far.
Straight.
Yeah.
The hydrocision can any direction very effective to remove the disc.
Because I don't have any experience.
Also, it's very difficult to remove too much of the disc tissue.
So what I would recommend is this is a very technical pituitary. It removes tissue. What I would recommend is they have a setup out there of some meat, and you can use it and see the efficiency of removing the material. This removes material in a very predictable and efficient way. And it's hard because you're not actually seeing material and pulling it out. But yeah, we've studied this, and it works very efficiently. So you just have to have the confidence that it's doing that, because you're not going to see it in your hand. Yes.
Talking about the recurrence rate, after you're changing from the open method to the percutaneous method, do you see any change in the recurrence rate? And also, what is the usual time frame that you see a recurrence of the symptoms?
The problems I've seen with recurrences with this have been mostly in patients not following post-operative restrictions. So I still limit them 30 pounds of lifting for 3 months. I still, and the problems I've come into is usually about 3 weeks afterwards they're feeling pretty good and they do things they shouldn't do. One guy mowed a lawn. He's mowing his lawn. And he did it. If they follow the restrictions, I've noticed a significant decrease in the recurrence rate. I haven't studied it to give you numbers, but just my personal experience. It's not zero, but it's much less, and it does happen in the first 3 months still. So that defect still needs to heal, even though it's a smaller defect. Okay.
What's your suggestion for the post-operative care for patients?
Post-operatively?
Yeah. The daily activity.
Yeah, I restrict, I guess the biggest thing is just restriction of lifting, 30 pounds. Probably no one actually follows it, but that's still, I put that restriction, and that's in place for 3 months. I used to brace, but I don't brace anymore. Probably the majority in the US still brace. They put a back brace on for that time. I begin physical therapy at 4 weeks. Low impact, no running, but bicycle, elliptical, things like that, swimming. And then at 3 months, there's no restriction of activity. So I still restrict them for a long time, but that helps to minimize the chance of recurrence. It's the same restrictions really I have for open. It's the same as open. Yes?
Do you have any experience about fail to the hydrocephaly and then how do you do this case? Fail to the hydrocephaly.
Failed cases?
Yeah.
I've not had anyone who didn't get some relief. I've had a few patients that had recurrence, and sometimes it's been a short period of time, just 2 weeks of the pain, and it might be just not enough disc material was removed. I've had older patients that didn't do as well, so I think anything above 50 years old is probably not the best procedure to do. I think the disc, the causes of radicular pain in that age population is much different than the younger patients. I've not had any nerve injuries. I've not had any type of motor deficits or numbness or procedural related complications. So. And that's pretty true. I mean, following throughout all the data that we've collected on this, the complication rate is extremely low. It's mostly picking the right patient is the key to success. But the risk of injury or the patient's doing worse with this is extremely low. So it's a good, excellent safety profile.
Before your procedure, do you recommend it epidural route before your procedure?
You know, my position on that is evolving. There's been some recent literature in the US that the epidural steroids don't really have any type of positive or negative effect on the outcomes of herniated discs. So up till now, 100% of the patients had a trial of epidural steroids before getting this. I might start to alter that, to be more aggressive. As I've gotten more cases and I have more data on this procedure, I'm finding that I don't necessarily have to go through the epidural steroids before trying this. I'm not saying that's what that's not where I am now, but that's where I'm evolving to be. I think if you look at the treatment algorithm for herniated discs, you know, this initially for me was just before surgery. But as I see the data coming back, and it's pretty positive, it moves closer and closer towards the non-operative side, further away from the surgery and more towards epidural steroids and possibly maybe just one attempt at an epidural steroid and then this. I think that's sort of where it's landing right now, rather than multiple attempts at steroid injections before going on to this. Because the data is just not very strong on steroid injections as far as getting real clinical improvement. But right now, yes, epidural steroids on everybody. Okay. No more questions? Good. Very good.
And then we have a lunch first.
Lunch and then surgery?
Yeah.
Okay.
30 minutes later we go to the
Thank you.